Welcome everybody. DeBakey CV Live. We're discussing atrial fibrillation. January 3rd, 2023. Happy New Year to all of you. This is the first DeBakey CV Live on AFib of the year. As many of you will recall, last year we did this at 5 p.m. first Tuesday of the month, Central Time. We will continue that this year. There will be a few months where the crew, the producers take a little break, usually in the summer, so we'll miss a couple of shows. Otherwise, tune in, join us for a conversation. By that I mean you have the opportunity to send us your question. It's rare that you get this free medical advice. We won't call it medical advice, but we can give it an opinion, say, on, in this case, atrial fibrillation. You'll see on the screen 2 ways to contact us. That's during this hour. And please get your questions in as early as possible so we have enough time to get to all the questions. We always get great questions. There are no bad questions. If you have a question, don't hesitate. Either go on your phone. You can go to 37607. Text DeBakey, and you can text your question. Or if you have a computer, you go to POLEV, that's POLEV.com, enter DeBakey, and respond to the activity. So there are 2 ways to send your question to us. We'll take your questions, we'll answer them. The question can be for me, it can be for my guest, it can be for both of us. We also have some questions that people have sent in on the Facebook page, Live at AFib Free, and that's wolfminimais.com. That site's run by Sandy, and let's see. Yeah, so we have questions from them, and those are teed up as well. So, you're listening to a DeBakey CV Live webcast. This was started by the head of DeBakey, Dr. Lumsden. He is now the head of DeBakey Heart and Vascular Center. We're at Methodist Hospital. This is at Texas Medical Center in Houston, Texas. So you're in Texas, you're in Houston. We're coming to you live from Texas Medical Center, Methodist Hospital, specifically DeBakey CV Live in our studios here. That was my job number 1, give a proper introduction for the year and Happy New Year. Job number 2, I came back to Houston from the holidays, and my son Travis picked me up, and we went to watch the Bengals play the Bills. We missed the first, I don't know, maybe 30 minutes. We turned on the TV, and it was all commercials. I thought, okay, well, they throw some in there, but there were like 10 commercials, and I said, what is going on? Then they came back on. It turned out someone was injured in the game. And we just saw at one time a brief replay of the play where this Buffalo Bills player was injured. And Travis and I both thought this was probably a injury based on where the player was hit in the chest. And I have a slide for that, if we can bring that up, because I'd like to just mention it briefly, because it is an arrhythmia, so it's appropriate to discuss it here just for a minute. Commotio cordis, and Travis and I both, he's not a physician, but we both thought this was what it was. And this is a situation where if a hit is delivered to the chest, just to the left of the breastbone in the 3rd or 4th intercostal space, just at the right time of the cardiac cycle, when the heart has already pushed the blood out and now is relaxing, starting to fill, that hit can create an abnormality in the electrical system, and the heart goes into what we call ventricular fibrillation, where the heart is shaking but not beating. And that would be consistent with someone getting that hit, getting up, and all of a sudden just not having enough blood going to the brain, and would just collapse onto the playing field, which is what we saw. It's very rare. It's generally reported in baseball pitchers, usually in Little League. People that have not a completely developed chest wall, the ribs are soft, and it's commonly, although it's rare, it's commonly seen when it does happen in a pitcher in a Little League game, and the batter strikes the ball and hits the pitcher dead on, just in the right spot, just as the heart is relaxing in that cycle, and can cause ventricular fibrillation and is a cause of sudden death. If CPR is not available, if a defibrillator is not available, it usually results in death because not enough blood gets to the brain because the heart is not beating. The treatment is to defibrillate the heart to get the heart to go back into rhythm. And you have about 3 to 5 minutes before the brain is not getting enough blood, and you start to lose tissue of the brain and brain damage. So you have to act quickly. That's probably what we think probably happened at the Bengals game, the Bengals-Bills game, and we think that's the cause of it. We don't think he had any underlying problem. It's rarely seen in football, more commonly lacrosse or baseball, from the ball hitting the chest. And it doesn't have to be a hard hit. It just has to be at the exact right time. 1 in a million. 1 in a million. My third job is to talk about AFib. We're very fortunate to have a guest today. Dr. Thompson is here. He is an orthopedic surgeon. He was the main orthopedic surgeon at Lake Jackson, Texas for many years. He's had a distinguished career, but he also had atrial fibrillation. He has an interesting story, and his story will help us talk about some different types of AFib that maybe we don't always discuss. In addition to that, we have a lot of questions. I'm going to take one question now before I introduce Dr. Thompson, just because it's been up there for a while. Are there any conditions that would preclude using the left atrial appendage clip? In other words, are there times during the mini maze where we can't use the clip? There are, but they are few and far between. Number one that I see is that the patient already has a device in the left atrial appendage. And almost always today those are the Watchman devices. So the Watchman device is more like a cork going inside the appendage trying to close it. But the cork, the Watchman, does not electrically isolate the appendage. And that's an issue, because if you have AFib and you want to get back in rhythm, not only should you close the appendage, you should make it electrically silent so it doesn't contribute to AFib. The Watchman device doesn't do that. But if a Watchman device is in place, then that would preclude closing left atrial appendage. It doesn't preclude having a mini maze. I still do the mini maze. I've done it many times, but it precludes closing the appendage. The other issue is if there is a big clot in the appendage. If there truly is a thrombus or clot in the appendage, then we can't squeeze it closed, because we could squeeze the toothpaste or the clot out into the heart, and that could go to the brain. So the two main issues are a Watchman device, which doesn't stop one from having a mini maze, and a clot in the appendage, which we make sure is resolved, or we have to do an open maze to approach that. So that's a short answer to that. With that, I'll introduce Dr. Thompson. Thank you so much for joining us, orthopedic surgeon, Lake Jackson. I think maybe the best thing to do is just tell us where you are and tell us a little bit about your story. Welcome to the show.
Thank you. Thank you. It's good to see you again. I'm 78 years old, and I started having rapid heartbeats intermittently 15, 20 years ago. And then I probably went into atrial fib 15 to 17 years ago. It was picked up on an insurance physical. And so I was placed on Coumadin, and just told to kind of live with it at the time. I called a cardiologist in Houston that did intervention that I'd been told about. And after talking to him, he gave me the same advice. At that time, I wasn't having any issues or symptoms, so just live with it and take the blood thinners. And that's what I did for the next 7, 8 years, 9 years. And eventually I was changed over from Coumadin to Xarelto, but I really did pretty well. I was able to go skiing and go to altitude in Colorado. But in the last several years before I retired, which was 7 years ago, I retired. A couple of years before that, I'd noticed that at altitude, if I went out and started to do rapid walking, I would start getting a little short of breath, more than I'd noticed before. And things kind of just carried on like that. I noticed some gradually increasing fatigue with yard work and with walking, and I thought it was my age, and maybe it was partly that too. But I did notice that my heart was beating irregular occasionally, but not very often. So I went to dinner with my wife and another couple in January of this year, and I'd watched the Alabama football game that afternoon. And we went to the game. Went to the dinner. I was going to kid the lady that was with us because she's a real Alabama fan. We had a dinner that night. They asked me evidently if I had seen the game, and I told them no, I hadn't. And then I ordered steak, ate the steak, enjoyed it, but don't remember it. I came home, and my wife realized there was something different, and after she told me what had gone on, I realized I didn't have a memory of that dinner, sitting with those friends, talking, eating, and talking about the football game. I just didn't remember it at all. We went to the emergency room that night, and I was worked up with EKGs and evaluation and CAT scan of the brain that night, and nothing was really found except for the AFib. And then I had medical workups, saw a neurologist, and then saw the cardiologist. Nothing was found on any of the workups. My exam was normal except for the atrial fib. There had been evidently an apical scar in my heart that had happened in the past. Sometimes we didn't know about it, but it showed up on the echocardiogram. But the flows were pretty good. My left atrium was a little bit enlarged. So I was referred by the cardiologist to have a Watchman procedure, and I saw one of the cardiologists in Houston at the DeBakey Clinic, and he graded me on the Medicare scale for a Watchman procedure, and I didn't score high enough. I only scored 3 or 4 or 5 points, and you had to score like 8 or 10, as I recall. And but he wrote down a name on the back of his business card and gave it to me, and it had Randall Wolf on it. And so I went home and looked up Randall Wolf and went to the YouTube sites, and well, I just decided pretty quickly that I wanted to give that a try and talk to Dr. Wolf about it. So we had a telephone conference a little after that, and then on June 1st, I was admitted to the hospital there in Houston at Methodist and underwent the Wolf mini-maze procedure with a clamping of the atrial appendage. Came home 2 days later. I had COVID a day or two later after that, but so it kind of delayed my recovery, I think, made me more tired. But a week later, after the procedure, I saw Dr. Wolf in his exam room, and he put in a Medtronic link, a little monitor thing to watch the heart rate remotely. And I think that's pretty routine for his patients. And I've seen him a couple times on telephone conferencing since then. Things have gone well, and I've stayed in normal sinus rhythm, and I've noticed an improvement in my health and stamina. Got some other issues, with back pain and stuff like that, but I'm able to do more yard work and able to walk a little better since I got off of since I got rid of the atrial fib.
Dr. Thompson, you had your mini maze about, I guess, 8 months ago. But
June 1st.
June 1st. Okay, yeah. But before that, you were out of rhythm, we think, for a long time. years, correct?
Oh, somewhere between 15 and 17 years.
It's often said by some people that this procedure has no chance of helping the heart if it's been out of rhythm even continuously for 7 days. But we found that not to be the case, at least in my practice. Even patients such as yourself, where the heart's been out of rhythm for years, still respond very nicely. I looked at your link, the Medtronic link, this afternoon before I came over here, so I'd be armed with the latest information, and it looked like perfect sinus rhythm to me on the link. So the link that you had placed, I think we told you, has a battery life of about 5 years. So we'll be able to follow your rhythm, and if there's any change, we'll know it.
Right.
Now, another point I'd like to make is that the echo showed that the left atrium was somewhat enlarged, but we did a CT scan before the surgery. The CT scan is much more sensitive, specific, and it measures the amount of blood in the left atrium. And normal, it's about 40 or 50 milliliters of blood. Yours was about 195 milliliters, which is huge. So on the CT scan we saw, consistent with the heart being out of rhythm for many years, a very large left atrium, very large. And in my own experience, if it's more than 200 mLs, it's difficult to get the heart back in rhythm. But that's a not exact number, but in that ballpark. So you were getting close to that. Nevertheless, you're staying in rhythm. And I think one of the reasons is you had not had any previous procedures, no previous ablations, correct?
That's correct.
And I think that muddies the waters then when you go multiple procedures in a very large left atrium and then try to do the mini maze. So that's just an important point. The other point is that you're not taking blood thinners anymore.
That's correct.
And I guess you had been on blood thinners for a long time. I guess you tolerated them pretty well. Were you still on the old Coumadin, or did you switch to a newer one?
No, I switched about 4 or 5 years before I retired, which would be 10 or 12 years ago. I switched to Xarelto.
Okay. And another point I'd like to make, and I've found this to be very helpful in situations where the heart's been out of rhythm for many years, it has been helpful to place the patient on an antiarrhythmic before the mini maze. And the one that works the best is amiodarone, but in a low dose. And that last part of the answer is very important, last part of that sentence, in a low dose. So if you take a very low dose, there's less chance of a side effect, but yet you get the advantage of that antiarrhythmic being on board at the time of the procedure and immediately after the procedure. And I think we probably did that in your case. Is that right?
Yeah, I started it 6 or 8 weeks before surgery.
Yeah. So even though it's said that these type of procedures won't help people who have what we call chronic AFib, my experience, my results have differed with that. And in fact, it has helped. Let's take some questions. And by the way, again, you'll see it on your screen from time to time. You may send in questions for Dr. Thompson or myself or for both of us during this hour. As you see there, how to join the conversation, either by text 37607 to DeBakey, or if you're on your computer, go to pullev.com. Let's take some questions, Dr. Thompson, and see where we end up. Where does the name mini maze come from? Well, it's kind of a strange story. I operated on a patient in Cincinnati. He was a skydiving photographer, so he would jump out of planes with skydivers. He had a camera mounted on his forehead, and the activation of the camera was in his mouth. And he would take pictures of people skydiving while he was falling with them, and he was grounded. He was grounded because of AFib. Couldn't do it anymore. That was his livelihood. George Rabe came to me He said that he thought the mini maze might help him. He had the mini maze procedure. He was one of the early patients, probably first 20 or 30 patients, and we're way past 2,000 now. And he got better. He could skydive again. He started skydiving photography again. And the local news, one of the local news stations had him skydive. And they filmed him skydiving and coming down and showing how much better he was after he got rid of his arrhythmia. So George Rabe came to me about a year later and said, "Doc, I got a present for you. Christmas present." I said, "George, you're in rhythm. That's enough present for me." He said, No, I really mean I got a present." And he opened up, it was a desktop. Took me to a desktop and he said, "You need a web page. Nobody knows what you're doing. You got to get the word out there, and this is how you get on the web." And I looked at it and I said, "Well, let's talk it over." He said, "No, it's already done." He pushed a button and it said Wolf Mini Maze. So the Wolf Mini Maze came from one patient who was very happy that he could do skydiving photography again. He got it from a combination of the maze procedure, which is an open heart procedure, which works well, and the fact that he only had little incisions, so he called it a mini maze. It's not really a mini maze, but that stuck, and that's what it's called today. I did not name it myself. I called it bilateral pulmonary vein isolation and ligation of the left atrial appendage, and that name just doesn't cut it on the internet. Here's a question. Haven't had Wolf Mini Maze yet. My date is coming up. I was told by another doctor that as long as my pulse stays under 100 while in AFib, that I would not have to be concerned about a clot forming and a stroke. Is that correct? Thanks, Dr. Wolf. Not exactly. If the heart's out of rhythm, the blood slows down in certain places, and particularly the left atrium, because the two upper chambers are not beating, they're just shaking. And we all know, especially surgeons know, that if the blood slows down enough, it will clot. It doesn't matter if you're a squirrel or a raccoon. If you're a mammal and the blood slows down too much, it will clot. So I don't think it's really based on what your heart rate is. It's really more of just having a cul-de-sac, a dead end, that being the left atrial appendage, and the blood gets stagnant there and can clot. So I don't agree with that. I think you can still be concerned. So we continue the blood thinner until 3 or 4 days before surgery, and about the time that the blood thinner is wearing off, then you're having your procedure, the appendage is closed, and then you no longer need to take the blood thinner. It looks like there we go. Now we're working here. Okay. Let's go to another question. It says, if you're able to clamp the left atrial appendage, is the stroke risk still reduced to 97%? Yes. Once the appendage is closed, regardless of whether or not the heart is in rhythm or not, the risk is reduced by 97%, and you don't have to take blood thinners. The stroke reduction with Xarelto, which Dr. Thompson took, or Eliquis, or Pradaxa, or Coumadin, is about 60% AFib stroke reduction. So you decrease your risk by about 60%, which is okay, but it's not that great. Whereas closing the appendage, you have a 97% reduction in AFib stroke, and you don't have to take blood thinners anymore. So that's important too. Let's see. Let's take another one. My heart rate is 80 when I had a stroke. There you go, low heart rate. I just came out of AFib. Your CHAD score, that's I think what you were talking about, Dr. Thompson, the CHAD score, the CHAD-2, is that correct? Mm-hmm. That's when they determined that your CHAD-2 wasn't high enough to warrant a Watchman?
Right, and they said Medicare wouldn't approve the procedure unless I scored a higher number of points.
You could have lied.
I know. I even had a TIA, but that didn't qualify me.
Your CHAD score determines your stroke risk, not your rate. There will be a link when the video airs. Okay, that's from Kathy Bryant. Well, the most important, as you're pointing out, Dr. Thompson, the most important thing about a stroke is that you're out of rhythm. So it can happen. So I don't pay too much attention to the CHAD score. I've had people come in. One fellow, he was 40 years old. He was ballroom dancing, and he just collapsed on the floor. And they took him to the ER. He had a stroke, and the doctor came out to talk to the family and said, "How long has Joe been out of rhythm?" And they go, "What are you talking about? He never had AFib." So sometimes the presentation of AFib is a stroke, unfortunately. So to me, the biggest risk is just AFib, and as you mentioned, the TIA. Who cares about the CHAD score? If you've had it, you've had it. You could say, well, your risk of having an automobile accident today is only 1 in 500. But if you've had the accident, it's 100 out of 100, right? So I don't pay too much attention.
And I thought it was a blessing that I didn't qualify on their scoring system, because I got referred to you that way when I was able to have the Wolf mini maze instead of the inside ablation and the Watchman.
Maybe somebody was looking out after you.
Maybe.
Is it normal, let's see, to have frequent flutter episodes after Wolf mini maze, sometimes daily? Will bradycardia resolve, or is a pacemaker the only way to correct? Well, some patients do develop flutter after the procedure. It's more commonly seen in patients who've had previous ablations, but sometimes it's in patients who've not had previous ablations. We can see flutter. This almost always takes care of itself. Occasionally we have to go back in with a catheter and burn a few areas that are outside the where the mini maze works, outside that area on the heart, and that almost always takes care of it. Sometimes they just slowly go away after a year. We've seen that. Sandy had that situation. So, and can flutter lead to VTAC? I've not seen that. Let's see. We got another one here. Oh, it's even bigger. Dr. Thompson, are you still on antiarrhythmic drugs? And if not, can you describe the process of weaning off? Good question.
So yeah, I was taking the amiodarone before, and cordis and metoprolol, which I'd been on for several years. I'm tapering off of the amiodarone now. Next week I'll start to take it just 1 pill a week and do that until about March. I still am taking metoprolol and cordis. And so I don't know how long I'll be on those. Maybe be on those forever. I'm not sure.
Well, it depends on your blood pressure. If your blood pressure is normal, we'll probably wean you off those one at a time. I usually do one at a time, otherwise you're not sure which one you're weaning is doing what. If the heart's been out of rhythm for a long time, particularly over a year, in your case, years and years, we want to be very slow about weaning the amiodarone, because in my experience, the longer the heart stays in rhythm, the more likely it'll stay in rhythm forever. So we want to wean slowly because it does offer some help. So a really slow wean is going from 200 milligrams a day to 100 a day. And then Monday, I think you maybe did Monday, Wednesday, Friday, or you did 100 a day for a while. I don't remember which.
A month of Monday, Wednesday, and Friday. That's right.
And then, I don't know, I go to 1 a week, which is a real piddly dose. But believe it or not, there are a few patients like yourself that have been out of rhythm for a long, long time. They take 1 amiodarone pill a week, which most electrophysiologists will say doesn't mean anything, but it helps keep them in rhythm. And the point is, after the mini maze, a little bit of antiarrhythmic medicine goes a long way. Now that leads into our next question here on the board. How long does it take for the amiodarone to take effect? Well, it depends on how quickly it's given. Sometimes patients are loaded with amiodarone in the hospital by an intravenous approach. And usually a loading dose is a gram, which is a lot of amiodarone. I generally don't use that because what I've found is if you want to avoid the side effects of amiodarone, it should be given judiciously in small doses. So that's why before the mini-maze, we don't give a big slug of amiodarone. We ask patients to take a small dose for 6 to 8 weeks, like Dr. Thompson did. And slowly it'll build up a little bit in the blood, but you won't have this high level of amiodarone in the blood. And that's worked very well. Side effects, complications from drugs are often associated with how much is given. And we all know the old story, if you drink enough water, it'll kill you. It's true with anything. So instead of giving a big bolus of amiodarone, which is sometimes done in the ER, we give very small doses over 6 to 8 weeks, and that works fine. And that generally avoids all the side effects of the drug. Then after the mini-maze, we try to wean the amiodarone over 3 to 6 months. It may take a little bit longer. I'm particularly slow in someone where the heart's been out of rhythm for years, many years. But if the heart's been out of rhythm for 6 months or a year, then we usually wean over 3 to 4 months. In Dr. Thompson's case, where we believe the heart's been continuously out of rhythm for a very long time, many years, and we know the left atrium is very large, then we do a really slow wean. So Dr. Thompson's amio wean is the slowest for those reasons. So how long does it take to get an effect? Depends on how quickly you give the drug. But if you want to avoid the side effects, low dose over a longer period of time wins the race. Let's go to another question here. 2 questions. How soon do you get off blood thinners after the mini-maze? Dr. Thompson noted that he stopped them after the mini-maze. I believe we didn't use them anymore. Did you take them for a month? I can't remember. Maybe you did.
Yeah, you suggested I stop them when just immediately or just within a days, but I'd been taking them so long, it took me a month to stop taking them.
But we had a reason, and I remember now, you had this history of a TIA.
I did.
And in patients who have a history of a TIA or stroke, I say if you want to be conservative, take the blood thinner for about a month after the mini-maze. If the patient has not had a stroke or TIA preoperatively, I do not continue the blood thinner at all. So that's a very good point. And I guess that gave you some peace of mind too.
It did.
Second question, do you recommend or think there's a benefit in using magnesium supplements? This comes up, magnesium and B12. I don't know. In general, if you think it helps you, I think that's great. I recommend that you take it in moderation though, and not big, super high doses. But I think in moderation it's fine. Keep in mind that almost all the magnesium in your body is inside your cells. So whatever you measure in the blood is just a tiny little window into maybe what you really have in your cells. So does taking a couple pills really change how much you have in your cells? I don't know. If you think it helps you, calms the heart, that's great. Some people think it does. There have been studies on both sides of that fence. Another question. My AFib is very sporadic with long stretches between episodes. I'm currently on Eliquis. Dr. Wolf put me on amiodarone, took me off Maltac since I'll be having the mini-maze in March. I'm on Toprol, 2 other meds for blood pressure, a few other meds for this issue. My EP wanted to schedule me for a 3rd ablation. Is it better to have the procedure when your AFib occurs more often in lieu of 4 to 5 times a year? Well, there's a lot in this. First of all, Maltac was an attempt by the pharmaceutical industry to get away from any side effects from amiodarone. Amiodarone is about 30% iodine, and it was thought maybe that's the issue. So they made a molecule that does not have iodine in the middle of the molecule. That's what Maltac is. So that was marketed as being safer. The only problem is it doesn't work, in my experience, especially for pre and post-op mini-maze. Multac is useless. So that's why we switched this lady to amiodarone. Now, is it better to have this procedure when your AFib occurs more often in lieu of 4 to 5 times a year? Nobody knows the answer to that. Like I said, I've had patients come in and their initial presentation of AFib was a stroke. So we don't know the answer to that. I don't think it matters really. I think once you're having it and let's say you're on medication, you're doing okay. Well, do you want to take that medication the rest of your life? You're doing okay, but you're on a blood thinner. Do you want to take that blood thinner the rest of your life? So there are other questions that come into this. It's not so cut and dry. It's a multifactorial situation. I have some patients that are fairly well controlled on an antiarrhythmic and a blood thinner, but they don't want to live the rest of their life that way. And they'd rather have something that's one and done and get off those medications. Generally, the antiarrhythmics will fail, but sometimes they work for several years quite well. Any comment on that, Dr. Thompson?
No, I would just encourage someone that's dealing with atrial fib and anticoagulants to try and have something done earlier rather than later. I wish I'd had it done years ago and gotten off the anticoagulants. I've had too many friends die from falls and hitting their head and car accidents that have been on anticoagulants, and we've lost them.
Well, that's an excellent point. One patient came to see me, and he'd seen me about 5 years ago, and he decided to continue to take the anticoagulants and the antiarrhythmic. And then he came in, about a year and a half ago or so, and he sat down. I said, "So you've changed your mind?" He said, "Yes." And he took off his baseball cap, and he'd had a craniotomy. He fell off a ladder, hit his head, bled into his head, had to have emergency neurosurgery to evacuate the blood clot. And he said, "Doc, I can't live like this anymore." And he was probably lucky he didn't die from that. So to your point, exactly. Another question for us, if one has done another maze procedure without success, can they still have the mini maze afterwards? Well, it depends on what another mini maze procedure is. The most commonly confused procedure is the convergent procedure. The convergent procedure is a procedure that has 2 parts. One part is the catheter ablation. The second part is burning the back of the heart, so the electrophysiologist doesn't have to burn the back of the heart. But it doesn't really address the issue. As many of you know, I have a fundamentally different approach to AFib, that being that the problem are the nerves on the outside of the heart. Now, burning from the inside of the heart may get a few of these nerves, but it rarely gets enough to really have a lasting effect. That's why catheter ablations, in my opinion, have so many problems. You're burning muscle. As a cardiac surgeon, I've seen the inside of the heart thousands of times. Guess what? There are no nerves on the inside of the heart. You got to burn through the muscle to get to the outside of the heart to get to the nerves from the inside. But then you burned up a lot of heart tissue. That heart tissue, once it's dead, doesn't come back. It remains dead for the rest of your life. My approach is an alternate approach, attacking it from the outside of the heart. That's where the nerves are. These nerves come from your brain, your hypothalamus. They go to the outside of your heart. They tell your heart to speed up, to slow down. And sometimes they get out of whack, and that is the mechanism, in my opinion, for AFib. So if you take care of those nerves right around the left atrium, then you have a better chance of curing the AFib. There are many of these autonomic nerves around the heart, thousands of them. We're just talking about the ones that are around the left atrium. That's the key. So if it's been a convergent procedure, very difficult for me to go back in there and do a mini maze. There's a lot of scar where the back of the heart's been scarred heavily and is stuck to the heart sac. Sometimes the appendage has been closed, which precludes me from going back into the left side and isolating the veins. So it's pretty tricky. I have done a few. From a technical standpoint, it's not an easy procedure. I'm sure Dr. Thompson can understand as a surgeon, if it's a fourth time in doing something, it's not as easy.
Scar tissue really makes repeat procedures much more difficult.
Yeah. Let's see, let's go to another question here. I would like Dr. Wolf to address his protocol for weaning off amiodarone, which I think we already did, and that is if the heart has been in rhythm within the last year, it's usually 200 milligrams a day post-op for a few months, maybe 3 months, and then cut it in half for a month, and then go to Monday, Wednesday, Friday for a month, and then you stop, or if the heart's been out of rhythm for a long time, go to just 1 pill a week for a month. And we taper the wean to based on how long the heart's been out of rhythm. Most common complications from the Wolf mini maze is another question. Well, the one that people worry about the most is what we call mortality. There's mortality and there's morbidity. Mortality is death. Morbidity are complications. The mortality here, knock on wood, has been 0. The only people that I know have 0 mortality from doing this are myself and my protege in Tokyo, Dr. Otsuka. We have 0 mortality, which is death rate. Complications, there are few, but it's never 0. Just like probably orthopedic surgery, it's never 0, is it?
Well, we didn't like talk about that, but yeah, you're right. That's right.
The most common complication is a post-pericardotomy syndrome. It's an inflammation of the heart sac. After any type of procedure on the heart, it can happen after even a catheter ablation. And that's inflammation of the heart sac, which is treated with steroids and treated with an anti-gout medication, a very old one, coltracine. Works very well for the post-pericardotomy syndrome. That's probably a medication you're familiar with. From the orthopedic
pericardotomy. I don't think I ever dealt with that in orthopedic surgery. Are you saying pericarditis?
Pericarditis. No, I mean the anti-gout drug, coltracine.
Oh, yes, anti-gout coltracine, and yeah.
It works.
We saw that all the time.
Yeah, it works, and it works for inflammation in the heart sac too. I mean, you used to use it for inflammation in the great toe, right, from gout.
Big toe, that was the most common, and we'd use Indocin also, yeah.
Yeah. So the other complication, occasionally some fluid in the lung, which usually clears with Lasix, sometimes requiring fluid to be drawn off, but that's unusual. We occasionally have a patient get a blood clot in their leg. This is certainly known to your profession, orthopedic surgery. That was a problem from time to time, having blood clots in the leg after orthopedic procedure, which has been mollified tremendously by using pressure on the legs when possible, and then also blood thinners when needed. Is that correct? And early mobilization, right?
That's right. We wanted to get our surgical patients up as quickly as we could, and the SCDs, the sequential compression devices, the stockings, and the early anticoagulation were really important to us.
So we use the same thing. So because of that and the experience we learned from orthopedic surgery, DVTs or deep venous thrombosis after the mini maze are pretty rare, but not 0. Here's a question. I have moderate coronary artery disease in my LAD. That's the main artery that feeds the front of the heart, and circumflex, that goes around the back of the heart and the side of the heart. I have persistent AFib for over a year, maybe 2 years. Many coronary artery disease patients have AFib, that is true. Would the mini maze and LA clamp still be a good option for us? I'm hoping the answer is yes. I intend to try to get a mini maze and clamp in the hopes of avoiding being on anticoagulants and antiplatelets at the same time, as I will certainly be on at least 1 aspirin as I move forward, hopefully reduce my overall stroke burden. And is applying a stent also possible during the operation? 2 birds with 1 stone, so to speak? Well, that's a good question. Yeah, we see many patients have coronary artery disease. Sometimes we do the stress test before the procedure and find out they have untreated coronary disease that's significant, and we will place stents in the arteries. Occasionally, the coronary disease was undiagnosed and is so severe it requires open surgery, and we do the maze at the time of the open surgery, the maze part to treat the atrial fibrillation. More commonly, the stent has already been in, or we place it and preoperatively. We don't do it at the time of the mini maze because stents require, you're right, stents require anticoagulation. And we like to do that before, finish that anticoagulation protocol before the mini maze. So the heart is not, the blood is not thinned out when we work on the heart. And you're right, anticoagulants and antiplatelets lead to a lot more bleeding. So to take care of the AFib with a mini maze is a good way to do it. And generally you want to do it 6 months to a year after a stent, or if you don't need a stent, you just have moderate disease, then just go ahead and take care of the AFib. We've never had a problem having a mini maze in patients that have moderate coronary disease or in patients that have a stent. I hope that answers that question. Let's see here. And does Dr. Wolf have AFib? Not that I'm aware of. If I live long enough, I'll probably get it. My mom turns 96 in 2 weeks. And she didn't get any AFib until she was 93, I think it was. So I still got a little ways to go here. How do they determine who's a candidate for Wolf mini maze? Another good question. First of all, we have to have documentation of AFib. You'd think that would be pretty obvious, but some people present and they have symptoms, but their AFib has never been positively diagnosed. Now, you'd say, well, how could that happen? It happens a lot because initially the heart may have short episodes of AFib. It may be 5 minutes, it may be 45 minutes, and by the time that person gets to the emergency room and gets an EKG, the heart's back in rhythm. So they say, what are you doing here? Well, I had palpitations. Well, you don't now. Well, we've got a way to take care of that issue now, and that's to put in a link, just like Dr. Thompson had, that will record any episode of AFib that's over whatever number of minutes you put into the system. But generally, even just a couple minutes of AFib, it'll show up. So sometimes we diagnose the AFib with the link before the patient's had a mini maze because we don't have any objective evidence of the AFib. So number one, you have to have objective evidence that there's AFib, an EKG, or a link monitor or some other monitor showing that there is in fact AFib. Secondly, generally we want to do the mini maze in someone who has some burden. If you have one episode a year for 5 minutes, is that enough to warrant a mini maze? Maybe not. However, I remember one gentleman that had infrequent episodes. They would last for about 8 hours, but he'd only have them about 4 times a year. He desperately wanted the mini maze. You know why? He was working in Panama, and he was going to be working in Panama for the next 10 years. He was very concerned about the ability to get acute medical care in that country. He was very concerned about living with AFib in that situation. He had a tremendous amount of anxiety. By having the procedure and closing the appendage, he was done with it. He forgot about it. His anxiety went away. But generally, we want to see an AFib burden more than 1%, with some exceptions. The next thing is, what if the patient's already had open heart surgery? Well, I've done about 30 or 40 of those patients. It is still possible to have the mini maze if it's been coronary bypass. If it's been a mitral valve procedure, generally not. Also, we look. You could look at age. The youngest patient that I've done in my experience was 15 years old. young boy from New York who had an unusual genetic thing, and he had AFib at an early age. Also took care of his sister when she was 18 years old with a mini maze. The oldest patient is a young lady who's 90. She's about 92 now, from Victoria, Texas. So from 15 to 90, it's all over the map. Done a couple of patients when they were in medical school, done a few patients in college, and about 40 or 50 patients under the age of 30. So it does occur in young people. It's less common, but it does occur. What about patients who had a pacemaker? No problem. Patients who had previous ablation? No problem, with the caveat that we like to wait at least 6 months from the last ablation, so things are kind of healed before a mini maze is performed. Obesity is probably our biggest issue. Once the patient has a BMI of over about 40, it becomes technically more difficult to do the procedure. I have done the procedure on patients as big as BMI of 50, which is about over 100 pounds overweight. So whatever your weight is, add 100 pounds to that, and that's a BMI of usually around 50. But once the BMI is over 40, it becomes technically more difficult, and we certainly encourage patients to lose some weight before having the procedure. I have had patients lose as much as 80 pounds in 3 or 4 months before the procedure, so they were a better candidate for the procedure. It also got rid of their sleep apnea, by the way, which is helpful, and they could move around a lot better. The key to the procedure is being able to get up the next day and walk around. That's the one key, and it's probably maybe not that different in orthopedic surgery. Early mobilization is the key for us. Same for you, I think, isn't it?
Yeah, we would get patients up the same day or the next day, and they got me up at the hospital quickly after surgery too.
It makes a difference. Dr. Thompson, this is a question for you. Advice to give someone for early warning signs. I'm not sure what the warning signs are, but maybe of AFib, I'm not sure.
You know, I didn't really have any warning signs. Mine was picked up on an insurance physical. I think there were signs that people have. Maybe when I developed shortness of breath when walking up in the mountains in Colorado at 700 feet, that was probably an early warning sign to me. But I already knew I had atrial fib by then. I really didn't have any severe signs. I think shortness of breath, but if you're getting pressure in your chest and things like that, it's getting more complicated for you.
Yeah. Can someone have a case that's too bad to work on? Well, that's a loaded question. For example, I just talked to a gentleman that I operated on several months ago, but he wasn't a candidate for the mini maze. His heart was incredibly enlarged. His left atrium was incredibly enlarged, and we did the open procedure. So we still did a maze procedure, but we didn't do the mini maze. We did an open maze on the heart-lung machine through the breastbone, and he's staying in rhythm now. He hadn't been in rhythm before the maze for a long time. I remember another lady from Montana from a year or two ago, and she came to us, and we got the CT scan preoperatively, and she had blood clots in her heart. Her heart was also very enlarged. She'd probably been out of rhythm for a long time. Unlike Dr. Thompson, her heart got very enlarged with the AFib. Some people maintain a pretty good heart function like you did. Other people get AFib and they get what we call tachycardia-induced cardiomyopathy, and the heart function goes down. That's where she was. She had clots in her heart. We did the open procedure, a maze procedure on the heart-lung machine, and she's doing fine and staying in rhythm. So both of those had cases where it was too bad to do a mini maze, but it wasn't too bad to work on. We figured out a way to help them. Let's see. I think we got to start to wrap things up. I had a couple of things I wanted to mention. My good friend and colleague is a seventh level karate the belt is the 7th level. His name is Dr. Miranda, and I mentioned this business about getting hit in the chest, commotio, cordis. By the way, commotio we get the word commotion, means the heart's just shaking. And he said that is a karate move that can cause commotio cordis. And I think that was in Kill Bill 2, a movie I saw years ago. And I think one of the moves was a karate move where they go real quickly against the chest between the 2nd and 4th interspace to the left and can cause that sudden ventricular fibrillation if you get it just at the right time during the cardiac cycle. That's about all I had here. Dr. Thompson, any closing words of wisdom?
Well, no, I would just suggest if someone's dealing with AFib, I would certainly look at the Wolf mini maze procedure. I think it's a real blessing for me. I wish I'd have known about it 12, 13 years ago, but I didn't. But as soon as I did find out, it sure helped me.
And you can also look at it this way. It doesn't hurt to get an opinion. Some people are concerned about getting an opinion. What's wrong with that? Get an opinion, get a second opinion. Call and tell your story, and if it's one where someone can help you, and I'll help you. If I don't think I can help you, I'll tell you I can't help you, but it doesn't hurt. There's no harm in being evaluated, I guess, is what I'm trying to say.
And most cardiologists are actually surgeons, cardiac surgeons, are not going to recommend Wolf mini maze because they don't do it.
Well, that's true.
Many of them don't know about it. And internal medicine doctors don't know about it. I live 50 miles away from you, and no one referred me there to you. And I've asked them twice when I've gone back to them now, and they weren't familiar with the procedure. It's really an interesting thing. We need to let more people know.
Well, I want to thank you for helping to spread the word. Fortunately, these days we can do a virtual visit like you had with anyone from anywhere in the world, and we do. We do virtual visits with patients from all over the country. So unlike the old days where you had to come see the doctor or you didn't get a visit, now you don't have to come see the doctor to get a visit and be evaluated. I think that's one of the advantages of some of the technological changes. There are a lot of downsides, but there's some upsides as well. I want to thank everybody for tuning in this new year. I hope we all have a happy and fruitful 2023. Again, we'll be continuing these webcasts on the first Tuesday of the month at 5 p.m. Central Time. You can also contact me if you like at 713-441-9342, 713-441-9342, or go to the website, wolfminimaze.com, or you can also go to the Facebook site, AFib Free Wolf Mini Maze. Dr. Thompson, thank you for joining us today. I hope you have a great 2023. And to everybody in the audience, best of luck for the next 12 months. From DeBakey CV Live, so long, everybody.
Bye-bye. Thank you.